So, this is a 48-year-old gentleman presented with recent posterior wall MI, fair LV function, and angiogram reveals OM 100% stenosis. It looks like a thrombotic lesion, and proximal right 90%, low RCA. We are planning PCI, OM and RCA. Probably in this case I will not be able to show FFR which we wanted to and the problems with FFR, but here there is going to be something interesting as far as the imaging is concerned. I want to dilate this OM and then take both IVUS and OCT run, and then we discuss how you interpret thrombus in this type of plaque rupture lesion with IVUS and OCT.
Excellent. Now we see the angiograms very well here.
Yeah. Okay. So run through.
Sir, what do you expect from imaging as you are the experienced?
This is Anand. This is a plaque rupture case.
Okay, sir.
And a big thrombus there. Patient had posterior wall MI and transient hypotension and was treated in the periphery in Maharashtra, and then it was shifted. It is a recent MI, couple of days old.
And what will be your strategy for the OM ostia?
I was knowing you want me to put another wire in circ or what. I think we have a clean OM ostium. There is no problem. Hopefully, it's okay.
So imaging will help us to know how the lesion was
that's
extended.
right. Very true.
In this case.
That's right.
Yeah.
So EBU 3.5.
Yeah. That's a workhorse guide for us. I think for most of the labs in this country, or maybe even in US, I suppose.
I think worldwide it has become almost a default choice, and then we adapt and live with it, whatever it does.
See, I am finding it little difficult entering in. It's probably acute on chronic lesion.
Or there could be false lumen in there, right, from the ruptured plaque.
I'm not sure. It's going in some small branch there.
Yes, I think it's going around the lumen. Right there is the real lumen, I think.
Yeah, downside there appears angiographic.
It looks better now. We can take one injection.
There,
I think we are there.
Yeah. So what are the ways to treat the subacute thrombus? Acute thrombus more of the soft. How we should gel, or we should treat with the pharmacotherapy and approach, sir?
Yeah. I am just trying to align my guide catheter well. Yeah. Here I'll take straight away a 2.5 balloon dilate with a low pressure, and then we'll take both IVUS and OCT run.
I think there's a larger branch inferiorly, right? Looks like from
both branches they both look almost equal to me. I'm not sure. No, I think we are in the bigger one. I think so. Or there is one branch going down.
Straight down, yeah. But you're right, there is enough room to land the distal 2.5 balloon.
Yeah. And I won't go above 6 atmosphere.
And I think if you daughter it a few times, you will get a good look at it. Absolutely, that's great. Now if we pull it back out and take a picture, you probably see the whole circ.
Maybe, may not be. It looks great. Fine. It's a bigger one.
Yeah. So you're in the better branch.
Yeah.
That's
now, great. Professor Akasaka, do you think that we can have a good OCT image with this block, or we need to open it up?
It might be better to open a little bit, yes.
Okay.
by OCT. Yeah.
Okay, fine. 4. Deflate, I think. See, when the balloon moves back and forth, there is a significant fibrous tissue, I feel.
Yep, absolutely.
Scout.
The watermelon seeding.
Yeah, go up here. 6. 2, 3.
3,
2, 3. And now it holds. And then you can go 6.
6.
Still it is not breaking, huh? It has broken, I think. Deflate.
Yep, just about, yep.
Sir, is it NC balloon?
Yeah, it is NC emerge. 2.5, 15.
Okay. Actasia.
સામે શીથ મૂકી ગઈ છે
મૂકી ગઈ હવે. મૂકી ગઈ છે.
Let's do it. Okay. So first IVAS or OCT, give one modality and then subsequently other. We take 2 runs here.
OCT લઈ લો.
OCT? So first Sanjay is giving me OCT.
Professor Tejas, should you like to give some nitro before doing an OCT?
No. Not really. It is not mandatory. If you are comfortable with nitro, you do it. If you are comfortable without nitro, it is okay.
The distal wire doesn't want to go in the main channel, doesn't it?
No, I am not trying to push it hard actually.
Yeah.
Here also I will be careful. I have my eye on the distal tip of the catheter.
Yep.
That is pretty injury prone. And I think we have the area of interest available here. Okay?
Yes,
Sure.
we are
That's
good now.
it. Fluoro. Inject. Sorry.
Okay.
Okay. Yeah.
Nice image, yeah.
Should be a good image. Just એમને એ બાજુ જતા રહે.
Okay.
Yeah. So Professor Akasaka will evaluate the image. See, there is, it seems like a lot of fibrosis there.
Yeah, it's good. Yes. Right. Here is the region of thrombus, right? Yes.
Thrombus.
Can you hear Professor Akasaka's voice there?
Yes, very well, yes.
Okay. Here is the distal OM, right?
Yep.
Yeah.
Yeah. There are lots of, yes, basically fibrous and fibrolipidic plaque. Yes.
Fatty.
And then move to the proximal site. Yeah, some dissection here by ballooning. And also here might be this might be the organized thrombus or maybe, yes.
White thrombus?
Basically white thrombus, yeah. No shadow, right? And here is the proximal site. You can identify some cholesterol appearance, right?
Cholesterol crystals.
Yeah, crystals here. Okay. And some dissection, and this is just proximal orifice, right? And then the main branch.
So there is a landing zone.
Yes.
There's a good landing zone there.
Landing zone, just proximal site. Yes.
Yeah, that's a good landing zone.
Okay, try to measure the diameter, right?
I was.
So, yes, proximal landing zone diameter is 2.7. So you can use, I think, quarter size bigger.
3.
Yeah, so 3 might be okay.
So we are doing now IVAS evaluation. Let us see what diameter and what sort of picture we get with this high definition IVAS.
Yeah. Distal is, yes, about 3, right? Therefore, I think 3.25 should be okay. Yeah. And additional disease in the distal side.
Yeah.
So you try to cover everything, right?
I think so.
By only one stent. So distal diameter should be 2 point,
Okay. Really good. Contrast up.
yeah, EL to EL
Yeah,
is
and
3, right? Yes, yes.
Active दिखाई जैसा fellow. Okay. Fine.
Okay, yeah. So now Professor Akasaka will read the IVUS.
Start, yeah. From the distal portion, yes, you can identify some plaque, right? With some calcium.
Yeah.
And from
Sir,
3 to
please show the IVUS. We are seeing the OCT image only.
Yeah, just show the IVUS image. IVUS.
Can
Are
you
you
see
able to
IVUS?
see now?
Yes, we can see it now.
Yeah, okay. Already little bit pull back. Here is a distal, yes, another disease and jump between the disease and yes, this, right. Some calcium here, right, at the 9 o'clock, and also the yes. You can identify the vein just behind the artery, and then this is the main branch, right?
Okay,
The CX, yes, os, yes.
So again,
We
quite a healthy landing
Yeah,
zone. Can
yes,
you
yes.
measure?
Os.
Yeah. Kadili.
Okay, please. Yeah, right. Yeah.
Little beyond.
Yes, that a little bit, yes. We measure the lumen 3.6.
3.6.
Just proximal, right? A little bit. Yes.
Yeah.
Yes. Yeah. How about the media to media?
Media to media.
Right. 3.5. So quarter size down is 3.25, right?
So, but we thought of taking 3, right?
Yeah.
As per the OCT, OCT shows 3.25 media to media. 3 media to media. Here it shows, the inner, EEM to EEM, right? And here again EEM to EEM is 3.5.
Yes.
So what is the consensus? Yeah, Samir and Abhiram, what do you think?
Quick question for Dr. Akasaka.
Yes.
So how often do you see that the IVUS shows bigger numbers? I mean, that's unusual.
Yeah. Ordinarily, our data shows nearly
With high definition.
high definition. There are some data showing no significant difference, but I think around 5 to 8% bigger in IVUS compared with OCT.
I go with the 3.0, I think.
Yeah, I think, I might even say 275 and bring it up, but 3.0 probably be the maximum I would put in.
Just let us take an LAO caudal view, because I will be worried about not, shifting my plaque anyway in circumflex.
Right.
Let me check it out. I will take 3
Yeah, I think 3.0.
or even 275.
I think 275 I would feel more comfortable.
Because distally I might use a bigger balloon to make it look big, but not proximally. And my landing zone will be simply just before the ectasia, or a little bit of aneurysm, that developing aneurysm there, right?
Yeah, right inside
So-
the ostium, right?
Yeah, distal landing zone.
Distal landing zone is
Just before that sort of a developing aneurysm part,
Okay.
just proximal to it.
so you don't want to cover the last lesion
Right. There's
right
no
after the
disease
small
beyond.
branch,
Just show the previous view.
because I think on the OCT we saw a
No, let us do it again. Yeah. But in that case again, it will be a good discussion, because there will be some good ectatic segment and you will see some good malapposition also. So what is the length you are getting? It will be at least 33 then, huh?
OCT has very good assessment of it. On the OCT screen, we have good length assessment.
Yeah.
Poor man's length assessment we will do. Go
Yes.
to AP caudal.
Yeah.
Absolutely.
Can you see the
And let us
OCT?
validate it
Works
on
better.
OCT.
I think there's more confidence in the poor
Scout.
man's length assessment.
Inject. So 28 is more than
28,
enough.
28. Yes.
28 is more than
Yeah,
enough.
the length by OCT might be 26.
Yeah, so 28.
Yeah.
Yeah, that's fine. Perfect.
Yep.
So now again, just show me the last angio.
Yes.
Samir, I think
Yeah,
I will
meant three.
change my mind here, and
You
rather
get to
than
media,
taking
right?
275, I will take
We
3,
can control.
because if I want to give some more dilatation, I will be more comfortable in the middle part,
Okay,
in the ectatic part.
sure. I think according to both OCT and IVUS.
And here I will choose synergy,
And then
because
will-
the expansion will be easier.
Will you also deploy it at lower pressure and
Of
see?
course, yeah. I will do only that.
Right.
I will deploy at not more than 10 or 12, and then we will see. Go to LAO caudal.
Right.
Okay, keep it here. Let me put inside, and then we will go to LAO caudal.
So I think, this is a younger patient. Dr. Prasad is saying we can probably get away with more expansion here.
Yeah.
It'll be more accommodating. And also I think 3.0 at low pressure will give you essentially a 2.5, 2.6 anyway.
Yeah.
to
Yeah,
start with.
328 synergy.
I think this is the reason why AI will never come into interventional cardiology. It might give you numbers, but you still need a head.
Yeah. And that too arrogant head of an interventional cardiologist, huh?
It's true.
It's a bronze.
So Samir, this arrogance in interventional cardiology community has, evolved out of almost 2 decades of beating by cardiac surgeons, right? Day in and out.
I think that and the uncertainty of the outcomes.
Yeah.
When you deliver a good outcome in such an uncertain environment, you're bound to get somewhat
Go
arrogant.
to LAO caudal. So now this is going to be a very, very important view as far as I think I am fine. The circ will not be affected at all.
It looks
Go
like a
on
good position.
10. 11 is nominal, 3.08. I think we can go to 11. Just inject and see how the circ looks. Looks perfect, no problem. Deflate. Go to AP caudal. Acha, keep it here only. Let me simply remove this. Check whether I have done any compromise on the circ. No, not at all. Go to AP caudal now. Just check it. So now it's a $1 million question. How aggressively you dilate and with what size you will dilate that ectatic segment and even the other segment.
Right. I think proximally, how big do you want it to be? That's what my question is to the.
So will you depend on the imaging, or you dilate and then you do imaging?
I would, in this case, I would depend on the imaging.
I too.
Normally I post dilate and then look at more optimization need, but here I'm not sure the proximal
So let
landing
us
zone is forgiving.
let us do OCT imaging, because we want to measure exactly the malapposition in certain region, and of course under expansion of in proximal area if at all. I personally feel that there is no under expansion. I am little careful about pushing my
डिस्टल बताए
by distal tip. Show me the distal tip. Oh no, I have to come out.
तो
No,
वायर पुश
just show me.
Can we see the fluoro screen? Yes, thank you.
This is better.
बेटर यस
जो तो
बेटर
Okay.
Yes.
It was not really so easy area to move.
I think the proximal
This is
stent
okay.
struts were probably in your
No, distal, bifurcation and a small area, negatively remodeled artery.
Yes.
we
So-
can't मतलब
So
accurate
yeah,
is-
this is all right.
I think that's
Not
about
more than this. Let me check it on cine. Okay, we are almost there. You want me to go little further?
I think the wire will
Huh?
have to be pushed out.
Little further, little further.
We have
Cross,
crossed. Okay, fine. Let's go in. Chalo.
Yeah.
Just tell.
We cannot identify any stent strut in
Yeah.
this portion,
Inject.
right? Yeah. Okay, Prabhat. Okay, great.
Yeah, it looks like a good image. Let us
Yes.
check it now.
Yeah. Very good image, right? We started the distal to the stent. Here is a landing zone.
Yeah.
Position is okay.
Yeah, perfect.
Yeah, expansion is okay, right? It's small, yes, under expansion in the distal.
And
Yes.
there you see mala
Yeah.
position.
Yes, yes. Before stenting, we measured 3.5
Yeah.
mean diameter at that portion, right? And here might be a small under expansion, right?
Yeah.
And the proximal side is, just proximal.
Perfect.
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 Right. Congratulations.
Yeah.
Great technique, right?
Perfect position.
Yeah. So what next?
3, 5, and C to high pressures in that aneurysmal area, and then
Yes. That's what we will do.
Can you see the 3D reconstruction in the proximal site?
Yes. We could, yeah.
Yes, here is the distal branch. You can identify the area, right? Just proximal site, we can identify the stent strut.
Yes. Perfect.
Perfect.
Very well seen.
So I will take 3.5 by 12 or maybe 15 NCE merge.
I think you might want to give it the banana shape because it will fight you going in.
You want, are there still young people sitting inside?
Probably, yes, I'm sure.
Then we can show that.
Yes. Making the balloon steerable, right?
Yeah. We can show that. Banao, banana.
Sir, I have
Yes.
one question.
Yeah.
With your experience, there was amazing ostial stenting that was absolutely perfect. In some cases, when we are finding difficult to place ostially, what are your views about keeping a balloon in the main vessel, inflating and pulling back the stent so that there is an indentation, the balloon-assisted technique for ostial stenting?
So the question was, would you inflate a balloon in the main branch to nail the ostium in the side branch with a stent?
I think
So
I know his
Samir,
answer.
you answer and then I will answer that question.
Not in this case. This
Just
case
now
was
let us
amazing.
focus how Sanjay makes the banana shape of the balloon. Just see.
Yeah, can we show close
Yeah,
up? to
yeah,
this
just
camera?
close up.
Yeah.
He has, threaded the balloon on the wire, and now he is giving shape to the wire. So balloon shaft inside tube will take that shape.
Yes.
So wire is distorted, but we don't worry because that part we are in any case we don't worry. So the balloon has that banana shape. Now you can go ahead with the discussion. No problem.
Yeah, I think, putting a balloon inflated at the main branch probably is not necessary if you have the right angiographic view, especially in this type of a bifurcation. In aorto-osteal disease, I think there is some description of methods of that, but I personally never use it. I don't know what everybody else's opinion is.
I even don't recommend to use it because that creates a lot of crowding inside. So this even doesn't need it. It straight away goes in.
Oh, that's nice.
Just
Cine.
inject and see.
Little back. Back.
Come back. Good.
That's good.
Go. Go on 12 here. Deflate. Now I come back and we'll go on 16.
Okay.
Come back at exactly now almost there near the aneurysm segment. Inside a little bit. Here. 16. Deflate. And now I will simply come little distal to the stand, my proximal this thing, at a very
Right
carefully in this area.
Yes.
Yeah, here you can go on 10, 11, nominal.
11.
That's it, deflate. So differential expansion is very important. You have to just see the sizing of the artery at different places, and accordingly you choose your expansion. This to me looks fine. One more OCT run and we should be done with this, and then we can work on the right very quickly.
Looks very nice so far angiographically.
OCT.
I think most of the post dilatation is done by what I call the oculosphincter reflex.
Yeah.
You look at the size and you see your body's reaction.
Yeah. In a calcified segment, when you see waste and when you are going high on the pressure, what is the point of time when you really perspire?
I think my focus is on the two edges of the balloon and the dog boning, because that's where the
if the waste up to 20 or 22 atmosphere, if it doesn't go and suddenly it opens up,
then you're then
yeah,
it's
I
trouble.
think of perforation first.
That's true.
I will deflate the balloon, inject. Again, if I see perforation, I will inflate the balloon and decide my strategy.
That is true. No.
The things are lesser now because of high usage of imaging, because we know the vulnerable areas which can give problem. जो तो डिजिटल वायर बराबर है. This catheter is a pretty delicate catheter to maneuver. Okay.
Join the scout side.
Join lo.
Fine.
It's good. Okay. Yeah, again,
Very good
looks
image.
like a clean image.
Yes, yes, I think so.
I think Sanjay Bhai's injection is something
Yeah.
that
Yeah.
we need
See,
to.
what he
nice
does, you know, Samir?
Yeah.
He is not worried about the timing of injection by that blue scale.
Yes.
He sees the movement of catheter and then he injects.
I think
Yes, yes.
the percentage of good images that we get in Apex is well in excess of anywhere else.
Yeah. Here is a distal landing zone.
Yeah, it's very
Well
nice.
expand and
Very
no
nice.
dissection.
Yeah,
And you can see the position indicator here.
Yeah.
All white. Yeah.
and
It's okay.
even if there is some malapposition, it should be within acceptable range.
Yeah, here is a branch. And also all, I think all slot opposed very well.
Very well.
Yes. Right.
JR ले लो.
Some tissue protrusion, but okay. And here is the just proximal site.
So slow score.
It's very nice.
Okay. Everything okay.
Yeah, view.
Fine.
Samir, you know what? These are the cases where I will always take one awkward view just to see the distal part of the OM. Go to epicranial. A little scout here. You can see that. The most distal part of the OM is seen so well. Because
Yes.
if you perforate here, it will straight away go in pericardium. There
That's
is
true.
nothing around.
Looks very good in the contralateral view.
And last view is RAO caudal. So I think that there is a regular RCA lesion, and it is already near. We are nearing 130, and we can go. If you want, we can go off live, and we can conclude here.
Sure.
We have 3 more cases to go. FFR case, unfortunately, is in the other lab. I would have loved, to do FFR and discuss on it, but I think we have to keep it for the next time. And I am so very thankful to you all, Professor Akasaka, Samir, Abhiram, all national guest faculty and all the participants to come all the way to this place, a dry place in the country, just, to spend 2 days. And I think we had some fruitful and hopefully sensible discussion, and we hope to meet again, sometimes next year with some even better agenda and with some better content. Samir and Abhiram, if you guys want to speak something to the participants, you can speak, and even Professor Akasaka, and then we can conclude. I am really thankful to my CAT staff, Sanjay, Aman, Rajni, everybody. Yeah.
I think this was, I have to say, this was a big round of applause. Thank you. Yes. It was an amazing inaugural conference for TRICO Imaging and Physiology, and well organized, great content, and I certainly learned a lot. I have to say that we have to continue this, and very enthusiastic audience. Big round of applause for our audience, please. Thank you. Thank you again, Tejas.
Thank you. Thank you.
Tejas, thank you so much. I mean, it's my first time to TRICO, but I'm taking away a lot of knowledge that I've gained. Actually, I'm not sure which way the knowledge went here. So thank you for inviting me, and
Thank you.
Really impressed with the work you do. So.
Thank you, Abhiram. We also acquired good amount of knowledge from you. Thank you. And Professor.
Yeah, it is really my great honor and pleasure to be here, and thank you very much for inviting me. All this Dr. Patel showed us very informative technique, and also the how to lead the physiology and imaging, right? It is very important for the next generation to learn from him, in this meeting, I think. So I highly recommend to come back again.
Thank
next
you.
year. Thank you very
And
much.
it is our honor to have you here. We learned practically everything from you. Thank you. Thank you. So we are going off live, and let us disperse for the lunch. And thank you very much once again.